Hello and welcome to Alumni Reunion, Home Edition. My name is Dr. Shah Mohammed from the Lawrence S. Bloomberg Faculty of Nursing. We're so happy to welcome you today to our annual Stress-Free Degree Lecture Series. While we're not in person, we know that these lectures will provide a great opportunity to hear from some of our leading professors on topics of importance and current interest, without the homework. Before we begin, a few technical notes. It's possible in this online format when we have some technical challenges. Please bear with us. If the stream freezes or drops, we ask that you wait a moment or two for us to sort out the issues. During this lecture, we welcome and encourage you to ask questions in the Q&A feature as seen to the right of the video screen. If you experience a technical issue during the lecture and need help, please use the Q&A feature to ask for support. Our speaker looks forward to hearing any questions you may have. And now we will begin our stress-free lecture series featuring Professor Elizabeth Peter, Beyond Pandemic Heroes, Reducing the Moral Distress of Nurses. Elizabeth Peter is a professor at the Lawrence S. Bloomberg Faculty of Nursing and a member of the Joint Centre for Bioethics at the University of Toronto. She's also chair of Public Health Ontario's Ethics Review Board and vice chair of the Bioethics Expert Panel of the American Academy of Nursing. We're pleased that she could join us today to provide timely insight into the challenges facing nurses during the COVID-19 pandemic. Please welcome Professor Elizabeth Peter.
Well, thank you for that very kind introduction. It's an honor to be able to come and speak during Alumni Week of 2021. I've been a faculty member here for a number of years, but I'm also an alum with both of my graduate degrees coming from the University of Toronto. Today, the title of my presentation is Beyond Pandemic Heroes, Reducing the Moral Distress of Nurses. I'd like to acknowledge a number of team members, and all of them have an affiliation with U of T in one way or another. Sean Mohammed, Tegan Kalaki, Jane McIver, Carolyn Varaya, Priscilla Boche, Michaela Gray, and Connor Chasen. And I couldn't have done this work without them, and it's a big thank you to them. I'd also like to thank the Toronto COVID-19 Action Initiative, which funded this work, and thank you to the participants who became involved and generously shared their time with us. So what am I going to do today? Well, first of all, I'm going to talk about stereotypes of nurses. And there are many, many stereotypes. I don't think I was totally aware of them when I first entered nursing. And the older I get, the more annoying I find them. But today I'm going to focus on three of them that are related: heroes, angels, and saints. And then I'm going to talk about what more realistically is nurses' work and their ideals. Then I will turn to our research, which has started to uncover what the sources of moral distress are during the pandemic and what things nurses are finding helpful with respect to reducing that distress as well. And you'll find as I'm speaking through all of these different areas that I think that the work that we're doing also has a lot of relevance to other healthcare providers as well. We focused on nurses because we are nurses, and that's the group that we know the best, and we know that nurses are the largest group of healthcare providers. So what are some stereotypes of nurses? This is Barbie, about 1960. You can see her in her cap and her black stripe. That used to be a really a symbol of nursing. Even when I started nursing, I was wearing a cap. And she's wearing a cape, which fits into the hero theme right now. But back in the day, nurses also wore capes. Some of the other stereotypes we know of nurses, that nurses have often been portrayed as angels. The nurse on the left is, you see the caption, she's the angel of mercy. She has wings, she's, healing the sick and providing a relief to their suffering. And on the right, you see a bit of a hybrid image of the nurse as not only an angel, but also a devil. This nurse is the sexy nurse, which also has resonance in common culture where we think of nurses in this way. The other thing that I think you'll notice about some of these images, and this tends to be the stereotype, we think of nurses often as being young, female, and in many instances white. So there are ways in which we really marginalize the nursing workforce because, of course, it's a very diverse group of people, and we don't fit into these stereotypes. As of late, nurses have often been characterized as heroes. You can see from this image, and many of you have probably seen this image before, it comes from Banksy. This appeared in a Southampton hospital. And here you see a child who's preferring to play with the nurse hero um, in the hand of the child, as opposed to Batman and Superman. So nurses have been portrayed as heroes, which is not new. It also happened during SARS. SARS, of course, was not as lengthy as COVID, but this has become a very common way of looking at nurses. The angels have also become very prolific. We see some murals here coming from Australia, some of them acknowledging and saying thank you to nurses, but the nurse imagery and the angel imagery in nursing has become really common over the last year. One of the most interesting things I found when doing research for this presentation was something that I found from Pope Francis when he spoke to nurses about a year ago on International Nurses Day. And he said, nurses are amongst the saints next door. You are an image of the church as a field hospital that continues to carry out the mission of Jesus Christ, who drew near to and healed people with all kinds of sickness, and who stooped down to wash the feet of his disciples. Thank you for your service to humanity. On the one hand, the gratitude is wonderful, and I think these messages are well intended, but there are many consequences to thinking about nurses as heroes and as saints and as angels. And I'd like to credit also Sean Mohammed with really thinking through what some of these messages convey. What does it matter? And what are the consequences of being viewed in this way? Well, there are many consequences. As a person who's been doing work in ethics for a very long time, what concerns me about these images and stereotypes is that they convey unreachable moral ideals. Nurses are not heroes, they're not angels, they are not saints. They're ordinary professionals going to work every day doing their best to provide care for people. And these unreachable moral ideals set up unrealistic expectations, expectations that nurses may put onto themselves, and expectations the society may also. Because, I mean, if you think of a hero, heroes often die for their causes, and we're not asking nurses to do this. What concerns me the most about some of these stereotypes, and with their very high ideals, that they may result in moral distress, which is much of the focus of my talk for today. Now, moral distress is a phenomenon that was labeled and identified and so on about 30 years ago by someone of the name of Andrew Jameson, who's a philosopher who was teaching nurses. And he recognized that nurses often didn't relate to some of the materials he was discussing in class. And their moral problems, he recognized, often were the result of being embedded in complex organizations. So if we move 30 years forward, there have been many different definitions of moral distress. I particularly like the one by McCarthy and Monteverde because it's a bit of an umbrella definition. They state the psycho-emotional physiological responses of an individual who feels unable to act in a way that they believe to be consistent with deeply held ethical values, principles, or moral commitments because of institutional or other constraints. In situations involving moral distress, the moral agent believes that moral norms are being violated and at the same time feels unable to act otherwise. So very high moral ideals sets someone up for failure because of all the constraints of everyday life. People do not realize the ideals of being a hero or a saint. Now, when Jameson started to identify moral distress, he was particularly interested in institutional types of constraints, recognizing that while nurses were not at the bottom of the hierarchy, they were not the most powerful ones in organizations. So often when their moral beliefs could not be realized in practice, they often felt constrained. Some of the typical sources of moral distress are often found at end-of-life care, when nurses believe that care or treatment is overly aggressive, and they believe someone ought to be able to die peacefully. So these types of distress is very common in nurses who feel, psychological effects of this and physical effects and so on. Again, it isn't just nurses. Other healthcare professionals are certainly experiencing moral distress as well, and other people in general are. But the term comes from nursing. Over the last year, for whatever reason, the more common term has become moral injury, which has come from the military. But they are very related terms. Moral injury is probably the more extreme end of moral distress. And while moral distress is a problem, there's also something very important in it. Any healthy individual, a morally healthy individual who goes into one of the health professions will experience moral distress. And on some level, that's a good thing, because moral distress alerts us to something being wrong. It may tell us that there's unrelieved suffering. It also may help us to gain insight into some of the power that we have and don't have with respect to the things we do in everyday work. So in terms of looking at the dynamics of moral distress, I've talked about some of the high ideals that exist. Later, I'll talk about the constraints during the COVID-19 pandemic, but there's also an element of nurses' work that involves proximity. And in order to describe proximity, what I've done is I have a short video clip for you, about 3 minutes, that was developed by the New York Times. It's a short film that describes and shows what everyday life is during the pandemic for nurses who work in an ICU. Again, this is particular to the ICU, and it's quite recently done.
I was looking through the window of a COVID ICU, and that's when I realized I might see someone die. I didn't even know who she was, but I was filled with immense grief as she edged closer to death by the hour. What I didn't know yet was that by the time I left just 2 days later, at least 3 patients would be dead. The vaccine offers hope, but the sad truth is that the virus continues its brutal slaughter in ICUs like this one in Phoenix, Arizona. The only people allowed in are our healthcare workers. They're overworked and underpaid in a deluged hospital. I wanted to know what it is like for them now, after a year of witnessing so much death.
Right.
Eager to show us their daily reality, 2 nurses wore cameras, so that for the first time, we could see the ICU through their eyes.
Unless you're actually in there, you have no idea. Nobody can ever even imagine what goes on in there.
This ICU contains 11 of the hospital's sickest COVID patients. Most of them are in their 40s and 50s, and they are all on death's door. It's an incredibly depressing place. I blurred the patients' faces to protect their privacy, but I also worried that blurring would rob them of their humanity. The family of this patient, the one who was rapidly declining, allowed her face to be shown, and they readily told me about her. Her name is Ana Maria Aragon. She's a school administrator and a 65-year-old grandmother. Sarah Reynolds, the nurse in charge of this ICU, organized a video call with Ana's family to give them a chance to be with her just in case she didn't make it.
It just breaks my heart when I hear families saying goodbye.
You might expect the doctors to be running the show, but it is really the nurses who are providing the vast majority of the care.
We do everything. We give them baths every night.
Rubbing lotion on their feet. Shave the guys' faces.
Cleaning somebody up that had a bowel movement, it doesn't even register as something gross.
Look, I walk into the room, I say, hey, sounds like you have COVID. Then I might order a chest x-ray, I might order blood work, I might order catheters. All that stuff is done by the nurse. I may have spent 10 minutes. The nurse might spend 7 or 8 hours actually in the room caring for them. Let's say there was a day that nurses didn't come to the hospital. It's like, why are you even opening?
12-hour-plus shifts, isolated in this windowless room. These nurses survive by taking care of each other.
You guys need your pay fields right?
Oh, thank you.
and by finding small doses of levity.
If you paid attention to the video carefully, you can see that many aspects of nurses' work are revealed by this video. You'll notice that the nurses were very team-oriented. They often worked together closely, and they also supported each other in their everyday work. The nature of the work was also very had a wide range. Let's put it that way. I mean, there were technical elements that the nurses were engaged in, and medical interventions having to do with all of the high life-sustaining types of interventions, all of this requiring a deep knowledge of the sciences and so on. They also provided what nurses call fundamental care, in the sense that they were caring for the body, everything from providing mouth care to body care and so on, which are, essential for the health and well-being of people. Nurses are also engaged in organizing work, in the sense that an ICU or any other hospital community work in nursing doesn't just happen. Somebody's also working on the organizing part, the logistics and so on. The other and final aspect, of course, is the psychosocial care that's provided by nurses. In the video clip, you will see nurses are very focused on the care of the one patient whose name, Anna Aragon, was actually made public. And at the end of the film, indeed, that patient does die, and the nurses facilitate, at least by video, the chance for the family to say goodbye. So nurses' work is highly varied, involves many different things. But the one thing that often characterizes nurses' work is what I call proximity. So on the one hand, nurses experience physical proximity. Nurses are normally very near to the patient's body. The so-called frontline nurses or direct nursing care is provided near the patient's body for long periods of time. Nurses have also been described as experiencing narrative proximity. That is, because of that physical proximity and the nature of what nurses do, they often understand the patient's story, the family story, and so on. Again, you can see this in that short clip of that film, that the nurses were very much engaged with the entire person, not just the patients. And you may ask yourself, well, what has this got to do with ethics and moral distress? The thing with proximity is it really motivates people to act. If you think about everyday life, for instance, let's say you're walking by a river and you just happen to be there and you notice someone drowning. Now, most people would act. Most people would act immediately. They would either call 911 or they would attempt to rescue the person, depending on their ability to swim, and so on. So normally, proximity beckons us to act. So nurses, in their everyday work, given their proximity to patients, are primed and highly motivated ethically to act, because that person in front of them is right there. If we look a little bit more closely about what nurses' moral ideals are, they're not of being a hero or a saint or an angel, but I would add that they're still quite high. In some work that we did several years ago, some narrative work of nurses and what they idealized, we found two things. We found that they found it very important to make a difference. So most nurses really idealize the need to make a difference in people's lives. Sometimes it's an individual patient, sometimes it's more at the level of populations or system change. So nurses find it important to perhaps see somebody get better, to provide support, or maybe to facilitate a good death, if you will, or to bring about organizational or system change, especially if nurses are working in more of an administrative capacity. So making a difference is part of a more realistic picture of what the moral ideals of nurses are. Again, they're still pretty high. The second thing we found that nurses often also find it important to hold the identities of their patients and their clients. So commonly, nurses are encountering people in what we call very vulnerable circumstances. Often people are very ill or they're in a crisis and so on. And nurses pride themselves or really try to help preserve a patient's connection, we would say, to the social and cultural world. They would really very much want to engage with family, to connect with that person in the meanings that they bring to experiences and their own entire history. Part of institutionalized work, whether it be in a hospital or a long-term care environment, is that there is the entire impact, if you will, of routinization and task orientation, which is sort of a competing force that nurses really do their best to resist and try to preserve the identity of people so that they don't reduce people to merely damaged bodies. And you can see this not only in the nurse in the film clip, but also the makers of the film really wanted to humanize at least one patient in one of the beds of Anna Aragon. So this is another one of nurses' moral ideals. So you can see that there are things that lead to moral distress with nurses: proximity, high ideals, and constraints. And much of the research that we've been conducting has looked at what are those current constraints that exist as a result of the pandemic and public health measures, I might add, and what are some of the things that might help solve or ameliorate nurses' moral distress. You'll find in what I'm going to begin to describe is that many of the constraints that nurses have experienced are a result of public health measures coming at a distance. And again, they are not without ethical justification. It's just that they're very much a blunt instrument, and nurses experience them in a particular when they are working directly with patients. So the purpose of our research, and I'm not going to go into all the, technicalities of the research methodology and so on, because I think that's a different presentation. But we conducted some primary data collection. We really wanted to explore what strategies reduce moral distress during the pandemic. We focused on RNs in diverse settings, and that's pretty much what I'm going to be focusing on. But we're also completing data collection right now with registered practical nurses in long-term care who have no doubt experienced the impact of the pandemic very directly. To inform our work even further, we're finishing up a scoping review, and we have looked at other published studies that have examined moral distress during other coronavirus outbreaks. So SARS and MERS, we learned a lot from them, those outbreaks as well, along with some emerging research on COVID-19. The methods that we used qualitative description. We wanted a rather straightforward approach so that we could find things that were useful and actionable. We also employed some concepts from critical bioethics in order to add to the depth of our analysis. We recruited our participants from the Bloomberg faculty graduate student listserv because they are registered nurses, and also through word of mouth and Twitter and so on. And we conducted interviews that lasted upwards of 60 minutes using Microsoft Teams because of the pandemic, we could not meet with them in person. So our participants, we had 24 registered nurses. All of them had provided either direct clinical care to someone with COVID-19 or the suspicion of it. And we did our best to recruit nurses from diverse areas. So we had lots of critical care nurses, we had community nurses, public health, street nursing, pediatrics, mental health, and so on. Most of those participants came from Ontario, but there were a very small number we were also able to recruit from out of province. So what were our findings? Well, the one thing we found consistently were that these public health measures in various forms resulted in the constraints I was talking about earlier. So the first constraint that we found is that nurses were morally distressed because of the prioritization of care for COVID-19 patients. Again, the prioritization of care for these patients isn't without justification. I mean, obviously we have, and even today, we have very critically ill people who need immediate care. But with that happening, there have been other consequences. One of those consequences is that there are people who are not receiving care. This transplant nurse said, certainly we all understand the rationale with initially stopping transplantation activity, and then restarting with only very critical life or limb cases. I can't help but think how many people have died waiting during the time that we put transplants on hold. And also thinking about the organs that essentially were wasted because the pandemic did not stop people from passing away. People were still passing. So this nurse deeply concerned about those people who didn't get transplants. I mean, I was listening to the news, I believe, yesterday, and I think it will take us about 3 years to, for the surgical backlog, if you will, to be cleared. So there are a lot of people not receiving care. We know that there have been a certain number of deaths because of COVID-19, but there are also going to be other deaths for people who didn't receive care on time. Another thing that happened as a result of the pandemic is that staffing models have changed. Many nurses have been redeployed in areas they're not used to. There are pediatric nurses taking care of adult patients. There are hospital nurses who have been working in long-term care. There are nurses unused to the ICU and so on. So there are lots of changes in the staffing models, which has resulted in this lack of confidence. And the need to provide highly skilled, competent care is, of course, a moral ideal. So this nurse said, because I'm not an ICU nurse, I'm not supposed to be caring for these patients independently. But I've had agency nurses that didn't look over everything that I was doing. So I think that you should review my rhythm strip or just take a peek at the patient to make sure they look okay to you. So feeling some degree of distress because they didn't feel that they were adequately prepared to provide care in an intensive care unit. We also know that moral distress has come as a result of infection control measures, because these too have compromised ideals of care. The one thing that we found repeatedly, and others have found this in their research as well, are the visitation policies. These visitation policies reduce family support of patients. And when I talk about family, I mean it in the broadest sense, because family is not just there to visit and to, have coffee. They're providing care and support and so on. So their needs, along with the patients, are all intertwined. One labor and delivery nurse said, and that was the worst thing, having to have someone in labor and people are in all kinds of emotional situations. She had had 5 previous losses, and she had finally carried a baby to term and developed a fever. And I had to ask her husband to leave. Can you imagine? It's just awful, just awful. So this nurse not only disagreed with the policy on some level because it did not allow them to provide the kind of care that would be normal, but also it's necessary for nurses to enforce these policies. And of course, and we've seen these situations many times probably in the news, this nurse said, usually when a patient is imminently dying, the family would be able to at least hold their hand, even if the patients themselves weren't conscious. That physical touch, I feel, was immensely comforting to the family, and that's not possible now. So having family present at death is an obvious, normal, a standard of practice and moral ideal that because of infection control policies were not always permitted. Now, those policies, of course, have evolved. Thirdly, the barriers of personal protective equipment, or PPE. And you can see that what this nurse is going to say resonates with this need to hold identity. And they said, and I feel terrible because the patients can't see my face, because I've got a face mask on, a shield on, yellow gown, scrubs, gloves, and it sort of removes yourself from the patient, And then you always have to say to yourself, this is a human being and not a body. So again, this need to maintain the patient as a full person and not just a body in the bed. And we've seen nurses and other healthcare providers do all kinds of creative things to avoid this impersonal impact of PPE by wearing a photo or placing their name on their face shield and so on. The other major theme we found was organizational influences that contributed to moral distress. We found quite a bit of variation in our research with respect to how organizations either contributed to moral distress or prevented it from occurring. But what I'm going to be presenting now are things that more influenced and contributed to moral distress. And these kinds of findings are sort of typical of moral distress research. So the first thing that we identified was no choice and a lack of transparency. So this nurse said, all of us were pretty blindsided by this decision, that is, to become a COVID unit. And I think also there was no input from frontline staff whatsoever when they made this choice. And that was difficult too. I didn't come to work to be told, you have no choice, you're now doing something that is far from what you would normally be doing. So again, this lack of voice in an organization is something that has been identified for over 30 years in the nursing research as something that contributes to moral distress and really limits moral agency and the chance to have an impact on practice. Another also talked about the lack of concern and support for nurses. In fact, there were a number of them, but this one said, the director for that governing body never even set foot really on a unit, any unit. That caused me a lot of frustration and moral distress also. I was struggling with just being on a COVID unit and working alongside others every day, trying to support them and lead them. Meanwhile, this large body that represents nursing and nursing professional practice was absent and disconnected, not on the same page. And this was very, very frustrating for me. So I think what's key here is looking at how this participant talks about no one ever stepping foot on a unit. So that proximity was not there. The leaders in this nursing body never really came to fully understand what was going on at the level of care because they didn't step foot on the unit, making the lack of proximity something that was deeply concerning in the eyes of this participant and several others. Okay, so let's begin to focus in on some of the more positive things. What relieved distress? And there won't be any sort of, magic bullet to relieve distress, but our participants helped us identify a few things. To no surprise, a number of personal distress reducing actions were identified, everything from exercise, TV, meditation, prayer, and so on. So these could be reducing distress more generally, they could be reducing moral distress specifically, but many of our participants found them to be helpful. But the most important thing we found is this one, and we found this throughout the interviews we conducted. Nurses talked about the support they received through their nurse colleagues, occasionally the interprofessional team, leadership, and professional therapists. But the thing that nurses spoke about most emphatically is the thing that helped them the most were their nurse colleagues. I mean, this ran throughout our interviews. This participant said, and your colleagues really are there for you. That kind of stuff has been a great source of support for myself and I hope for my colleagues. The colleagues that have been directly involved in the most distressing situations, I feel like speaking to that person and just kind of validating, yeah, that was terrible. Yeah, that was an awful situation. Having those feelings validated, I think, was probably the thing that has assisted me. So this, again, was very, very common. Some of our participants said that the only reason they were able to continue on and go to work was because of their colleagues who were there to validate their feelings, to support them, and they had a real understanding of what they were going through. Others spoke about the importance of leaders. This one participant talked about engaging in regular meetings with the supervisor, having reflective practice, and ended simply by saying, my supervisor is really good at filling up our cup. So while we found some leaders to be sort of distant and unavailable, we also found nurses pointing to some of the leadership as being extremely helpful. So that was very variable. And the interprofessional team also occasionally came up with this sense of, that they were all in this together, which has become sort of a cliche phrase. But indeed, some of them really were there together every day at work. We also wanted to know about professional therapists, especially those professional therapists that were part of something institutions put into place. And we received some mixed reviews. This participant said the psychologists were offering one-on-one support over the phone virtually, as well as EAP, or the Employee Assistance Program, but staff were very reluctant. And again, it felt like that whole layer of disconnect. Like, I don't want to talk to someone on the phone who can't possibly appreciate what I'm going through and what I'm living through right now. Again, and this is not, a criticism of psychologists or others providing that kind of support, but there just haven't been close enough to the care to fully understand. Other nurses also talked about reluctance of contacting someone because they were concerned about boundaries, if you will, in the sense that there were psychiatrists from the same hospital and so on, and that they may have worked together in other capacities. So a bit of a mixed review when it came to those professional supports that were put in place. We were also very curious about the discourse of nurse as hero. And here we received sufficient ambivalence. On the one hand, some people were, really delighted, if you will, that the public was noticing them. But more often, the hero discourse was met with ambivalence. And this quote, I think, summarizes it quite well. They say, I didn't become a nurse to become a hero. I'm doing the same. I have the same patient ratio. I'm doing the same work, and I'm giving the same care that I do every day of the year. And when this is all over, I'm going to be doing the same kind of care when all the hero stuff goes away. I'm still going to be working this hard. And I think that we should be using this time to just put forward, like, maybe we should get paid more. Maybe we should have more than a 1% raise. So this was quite common. Nurses were ambivalent about the hero discourse. I like the way this person says, when all the hero stuff goes away, and I suspect it will. It went away after SARS. And emphasize that maybe having a pay raise more than the 1%. And that 1% raise for many of our participants was rather insulting. And I was, again, in the news, there was a study of registered practical nurses who, I think the number one thing that they did ask for was more than that 1% raise. And that a raise would show appreciation much better than being called a hero or banging pots and so on. So our patients. Patients are also very helpful to nurses. And this is not only during the pandemic. There's other research that shows that patients' responses are very, really help nurses, stay in place, if you will, and feel quite rewarded. The first nurse talks about a patient becoming awake, if you will, and being able to nod appropriately and so on. And the nurse expressed how thrilled she was when this happened. And so this is, again, very rewarding. I think it reflects the moral ideal of nurses making a difference. And I really like the way participant 10 summarized it all and said, honestly, every time someone said, thank you so much for what you do. So the thank yous, very gratifying, small thing. But nurses during the pandemic, as always, found those things to be very sustaining. Okay, so where do we go with all this? How do I conclude this? I mean, there are a number of recommendations that we have thought of both individually at the organizational level, policy, and these come out of our research, but also through the research that we have looked at through our scoping review. Of where can we move forward, because it's important for the workforce to stay healthy and to continue to provide excellent care throughout the pandemic, which we all hope will end soon, but also after that. There's some fundamental things organizations can do, and many of them have gone a long, long way in the last year. Having those infection prevention and control policies in place and PPE. Thankfully, we're in a much, much better place than we were a year ago. And those things have lowered that sort of general distress level, not necessarily moral distress, but that general anxiety has come down, I think, quite a bit because those things are in place. There's still a need for those written visitor policies that really require nursing input. Nurses view practice in their own way, and having their input really important. These have evolved, they vary from place to place, but nurses really need that input. And the fourth thing, appropriate staffing. It's very easy to, for me to write that on a slide. It's another thing to have that actually happen in practice. This has been recognized forever that without appropriate staffing, we will not be able to have a workforce that's healthy, and we will not be able to have patient care provided at an adequate standard. So this is something that we need to really think through as society ages and so on, and we're also losing nurses, and God forbid that we lose too many more as a result of the pandemic, but we need appropriate staffing. The self-care activities continue on. Lots of research shows that they're helpful. I've gone over these before, but continue on at an individual level. I think, though, that what I think is most important is this notion of moral community that many people have begun to write about. Moral communities are places where people can be together in an organization as a hospital or a community health center and so on, where there's the opportunity and the space to have moral dialogue and support. For that to become normalized, for there to be mutual respect and reflection, so that people aren't struggling with moral concerns, simply on the way home in the car, if you will. But there is an openness, an ability to discuss these things. Sometimes ethicists can be very important in this. They can help open up that space, if you will. Leaders can be helpful both formally and informally. And as much as possible, any kind of in-person support is the best because proximity is so important. So moral community has, and I have some references on the bottom as well, has been shown to be important in other research as well in terms of both preventing moral distress and diminishing it. Those patient improvements and gratitude, those small things, as much as possible, if those are shared, they can be very important. Obviously, there are limits to this because of privacy, and not all of our patients can express gratitude. So it can't be an expectation either. But when those things do permit, to share those stories is really essential. Some of the things about engaging and supporting nurses providing direct care have been made before, and these are part of, these are recommendations that have gone on before the pandemic and afterwards as well. Decision-making needs to be transparent. Nurses providing direct care need to be engaged in that decision-making as much as possible so that they don't become voiceless members of large organizations. The educational opportunities that nurses have been provided during the pandemic have been very helpful. Many of the nurses we spoke with were very appreciative of some of the education they received when they were moved to new areas. The professional mental health supports for some nurses are helpful, others not so much, but for those who do find it helpful, it should be there. And of course, recognizing the need for time off and limiting overtime. And that right now, in May might not be a possibility, but we need to think about that going forward, especially if this were to happen again. So finally, what about nurses as COVID-19 heroes and angels? I think the important thing for nurses and other providers actually to do is to accept it with a critical mindset. It's probably coming from a good place, but nobody can reach those ideals. And especially during the pandemic, we need to accept that there are real limitations for what people can accomplish in practice. During the week, I looked at what the College of Nurses of Ontario were saying to nurses at this point, because they periodically update us. And they too are saying that nurses need to recognize that perhaps the standard of care under ideal circumstances is not being realized, but we need to understand circumstances, we need to understand context, And basically, the message was do your best. So I think this is helpful because if we bring that extraordinarily high ideal down to something that's on the earth and realizable, we'll have less distressed people. And ultimately, especially for people like me who've had the privilege of sitting safely in my home for the last year, it's important for all of us to continue to advocate for better working conditions for nurses. I think that things like that have happened in long-term care have really shed a bright light on all kinds of things, and one of them is about the working conditions for nurses. So with all of that, I hope that those things will be helpful in preventing and reducing moral distress in the future. So thank you so much for your attention, and welcome any kinds of questions or comments that you may have at this time.
Thank you so much for your attention during my presentation. I'm just looking at some of the questions in the chat box. Is compassion fatigue one of the measures of moral distress? Well, I think that those are related concepts for sure. There are, if you're thinking about measures and research, there are different ones for those two things, but of course they are related. The moral distress is more explicitly about ethics, but they are definitely related concepts. So different measures, but related. The next question is, nurses have suffered both physically and mentally during COVID-19. What changes do you hope to see put in place moving forward to benefit and better support nurses and healthcare workers? Yeah, I mean, that for sure. We've seen lots of health and wellness issues across all healthcare professions. Many of the things that I was talking about at the end of the presentation, I think are the things that we need to be very mindful of. And having that voice of our so-called frontline, although it's a military kind of word, provider in institutions needs to be there for leaders to understand what those working conditions are, what they need. I mean, no doubt, we need to make sure that we have things like PPE in place for the next pandemic, because we were caught off guard with respect to that. But also the mental health issues are there for sure. So having adequate people available is really necessary, to have that time off and so on, absolutely critical. That people are not expendable. They can't just come to work under any condition. Next question is, do you think the negative experience during the pandemic will cause some nurses to change careers afterwards? Yeah, I think sadly that is the case. With the study that we're doing with registered practical nurses, some of them already had left by the time they had participated in our research. That workforce, I think, is even more impacted than the registered nurse workforce. So yes, and when we're hearing this internationally as well, that people are leaving, there are people retiring as well. Interestingly though, I think that nursing schools across Canada have seen a real increase in the number of applicants. So I think maybe nursing is being portrayed in the media, or is being in the media's attention more. So perhaps we're getting more interested applicants that way, but we are losing nurses. And this is concerning. Again, I was reading something in the news about how much of an increase we're going to need in long-term care in the next 10, 20 years. So this is something we need to be thinking about, and what those working conditions are. Looking, next question says, are current mental health support systems for nurses going to be enough in the wake of the pandemic? Do those supports exist within most places of work for nurses? I think just as a society, there aren't enough mental health support systems. And there are some for nurses, to be sure, but many times too, benefits that nurses may have and others may have limit them, of course, to a certain number of sessions. and they're just not enough, given what some nurses are experiencing. Here again, there may be room for support groups for nurses as well with other nurses, so that they can have people near them that understand what they've gone through. And again, I really underscore the long-term care, because I think we've seen some of the most trauma, especially given the number of deaths. Our critical care nurses as well. I mean, nurses and other providers, of course, are used to working with people who are dying, but at this volume, and also not being able to provide the kind of supports, especially the family support, is very hard. The next question is, I'm in my 38th year of practice, and it's sad to say some of these same issues have existed throughout my career outside of the pandemic. The obvious disconnect for me is that leadership throughout organizations do not have a respect and understanding of the point of exchange of care. How do we fix this? Yeah, I've been in practice a long time too. I totally understand what you're saying. You know, moral distress was formally recognized over 30 years ago. We've had a lot of research and understanding about this forever. We found with some of our participants, when they had leaders who understood, who made time to understand what was happening right at the point of care, but we had many others who didn't. And it's concerning that the way healthcare is structured now, we have fewer nurses in leadership that are available, with the number of people